Hello, my name is Teresa Brannon. I am the manager for training and technical assistance at the National Center for Health and Public Housing. I want to thank you all for attending today's webinar, A Look into Maryland's Exchange Program, providing continuous quality care to your community. We are honored to have as a presenter Mr. Charles Milligan. Mr. Milligan will discuss eligibility and continuity of care as people move between Medicaid and the Insurance Exchange Program as described in the Affordable Care Act. He will focus on implications of the insurance expansion and the effects on the safety net, the remaining uninsured, and the holes in the safety net. Mr. Milligan will discuss the multi-payer approaches to the delivery system reform and the importance of being desirable in the eyes of commercial carriers and private payers. Mr. Milligan is the Deputy Secretary for Healthcare Financing at the Maryland Department of Health. In this role, he administers the state's Medicaid program and serves as the department's overall operational lead on healthcare reform efforts. Prior to this, Mr. Milligan was Executive Director of the Hilltop Institute at the University of Maryland, Baltimore County, which is a health policy research center that performed work for the Maryland Medicaid program, CMS, Medicaid programs, and other states and private foundations. Before joining Hilltop, Mr. Milligan was Vice President at the Lewin Group, where he provided consulting services to 20 states, testifying before 8 state legislatures, primarily involving the Medicaid program, public purchasing pools, long-term care rebalancing, and performance measurements in publicly financed health care. Prior to that, he was Medicaid and S-CHIP Director for the state of New Mexico. He has practiced healthcare law earlier in his career, and Mr. Milligan holds a JD from Harvard Law School, an MPH from the University of California at Berkeley, and a BBA from the University of Notre Dame. Mr. Milligan, please start your presentation.
Thank you. Hello, everybody. I'm going to be providing some slides and some background on what Maryland is doing with respect to safety net providers and leaving ample time for questions. So I'm going to just start the presentation. Here's the outline of the 4 topic areas that I'll be covering. First is continuity of care, which I'll explain what I mean by that in a minute. Second, capacity building for safety net providers. Third, delivery system reforms. And then fourth, safety net issues related to the remaining uninsured populations. So with respect to continuity of care, let me describe what I mean by that. In Maryland, we were looking at issues as people churn between Medicaid and the exchange. We looked at it from 4 dimensions with respect to Maryland, and then we worked forward based on that environmental analysis. We looked at it from continuity at the health plan level. In the Medicaid program in Maryland, we do use managed care organizations, MCOs, for delivering services to the vast majority of our Medicaid beneficiaries. In the Maryland Medicaid managed care market, there are a number of very large MCOs, none of which participate in our commercial market in any significant degree for the individual market or small group businesses. Similarly, our biggest commercial carrier in the individual and small group markets in Maryland is our state Blue Cross Blue Shield program, which is known as Care First in Maryland. And so we were hopeful at the very beginning of health reform a couple of years ago that Care First might have an interest in joining the Medicaid program and that some of the Medicaid managed care organizations might have an interest in joining the commercial market so that as individual Medicaid beneficiaries churned between Medicaid and the exchange, they could stay with their same insurance carrier. But when it became clear that the insurance companies were not likely to expand into those new markets, we had to then start tackling it from a different direction. We also looked at continuity at the provider level, and I'll be elaborating on this in a minute. This involves whether the beneficiary's primary care provider or treating provider might be in the network of the Medicaid MCO and the commercial carrier so that they can individuals can stay with their provider even if they're changing insurance companies when they churn. We also looked in terms of continuity at continuity for the benefits that are covered in benefit packages and what implications there might be involving utilization and authorization. Let me explain what I mean by this. One dimension of continuity is if somebody's going from Medicaid into the exchange, the benefit packages are not identical. Medicaid has traditionally, and in most states, a more extensive benefit package, so that if somebody is changing income levels and going from Medicaid into the exchange, even if everything else stays the same in terms of continuity, they might be eligible for fewer benefits, and that might create some gaps in what services they've been using, for example, specialty mental health. So we wanted to start mapping those benefit areas where Medicaid and the commercial, the essential health benefits in our state were not aligned. But also with respect to benefits, if somebody is in Medicaid and they're in the middle of treatment for a certain condition, or if they've had surgery authorized, for example, they've been through all of the analysis of whether they meet medical necessity, and an MCO in Medicaid has authorized the surgery, as an example, but then they transition into the commercial carrier, we thought it would be very disruptive for consumers to have to start over again. And so when we looked at continuity of benefits, we wanted to make sure that somebody could have seamlessness with their coverage. And fourth, we wanted to, and this is again the benefit package issue, where the benefit packages might vary. We focused on all four, and as I mentioned, there is not a lot of continuity at the health plan or carrier level. So our state legislature in 2012, the spring of 2012, a year ago, passed legislation requiring the study of continuity of care protections, and we had a very broad stakeholder advisory committee that was advising the exchange in Maryland, the Medicaid program, and our state insurance commissioner. This stakeholder advisory committee included consumers, consumer advocacy organizations, providers, provider organizations, local health departments, and a broad array of providers as well as the insurance carriers. The final report was delivered in December of 2012. It made recommendations including changing Maryland state law to enhance continuity of care in two specific situations. Changing our state law to simplify the process when somebody transitions carriers, including from Medicaid to the exchange or the other direction, in the middle of a course of treatment. And we wanted to ensure continuity where somebody could stay with their treating provider, their existing provider, even if the new insurance carrier they're joining is not in the network of the plan that they're leaving. So, for example, if a woman becomes pregnant and therefore might move from the exchange into Medicaid, how could she continue to see her OB if it's not, that OB is not in network, or a mental health provider, or other kinds of providers? We looked at the actuarial value of adding these new requirements to Maryland state law, and an actuarial firm was hired to do this study. The actual marginal cost was very small, partly because what the state law that we were going to propose was going to include was not adding benefits to any insurance product. We weren't going to, for example, require the qualified health plans to start offering Medicaid benefits, but for the benefits within a QHP, what would it cost on a marginal per member per month basis to enable the consumer to not have to start over again with authorizations, or to be able to go out of network to complete a course of care? And it only was projected to add about 7 cents per person per month to add those protections, because, as I said, it wasn't actually requiring any change in the scope of the benefit package itself, and it was only projected to add about 5 cents per member per month for Medicaid MCOs to have these protections. So law was introduced, a bill was introduced in Maryland in the session that began this past January of 2013. The law was passed. It has the following requirements. Maryland law requires that a receiving commercial carrier MCO, that is the new insurance company, has to abide by all prior authorizations for treatment of the benefits that are covered in the receiving carrier's benefit package, has to allow out-of-network access to care to complete the course of treatment, and that both of those requirements will last the lesser of 90 days or until the course of treatment is completed. And so the receiving carrier has the right after 90 days to help transition somebody to an in-network provider and to manage the care from that point forward. But a law was introduced and passed and will be signed by the governor shortly that would put in at least a 90-day period of time when there was complete continuity. With respect to safety net providers, why does this matter? And I've called out here on the slide federally qualified health centers. It applies to other safety net providers as well. First of all, there is going to be a lot of churn between Medicaid and the QHPs, and I've got some slides to show the magnitude of this in Maryland. These are health conditions that FQHCs deal with some frequency, including behavioral health care, including serving as a primary care provider, and also for certain FQHCs in Maryland, probably around the country, doing OB and other services. And so in Maryland, FQHCs and other safety net providers will be able to follow their patients from Medicaid into the commercial exchange for at least 90 days and be assured of being able to sort of have continuity with their patient. But after that, the QHPs in Maryland would have the right to then transition the patient to an in-network, independent physician, private practice physician, different kind of mental health or behavioral health provider, and so on. And so one of the issues that FQHCs in Maryland need to focus on trying to become in-network for QHPs and other safety net providers to get contracts and become in-network is that in Maryland, that will enable them to continue with their patients for more than 90 days. And I'm going to build this theme a little bit later on. So then we looked at churn, and this is this slide that's up now as we looked at a year's worth of data in Medicaid of the population that's likely to transition, and this is the figure at the bottom of the slide, the total for a year period of 880,000 people in Maryland Medicaid. The number at the top, all Medicaid of 1,130,000 people, includes long-term care eligibles and others who are likely to stay in Medicaid. This is populations receiving SSI and others that are not going to be part of the typical family and children groups and MAGI groups that will churn. So then we looked at eligibility category and group by group and at churn rates, and the roll-up you can see at the bottom. In the course of a year, about 67% of our population was continuously enrolled in Medicaid throughout the full year. In our state fiscal 2011, about 20% came into Medicaid, and we anticipate that a lot of these people in the future will be coming into Medicaid from the exchange. And so we're going to be honoring these continuity of care protections as Medicaid MCOs receive these individuals and have to honor out-of-network providers and also the authorizations and treatment. We then looked at the group that lost eligibility in the course of the year, in those groups likely to churn in and out of Medicaid in the exchange. And in Maryland, that was about 12%, or about 103,000 individuals. We anticipate that most of these people will be churning into the exchange because their income level rose or their household size changed in such a way that they became qualified at a higher percent of poverty. And then actually 1%, the next column, gained eligibility and lost eligibility and sort of churned in and out of Medicaid in a single year. So focusing on that 12% group that lost eligibility and will go into the exchange as part of the importance of this. We then looked at, for those people who lost Medicaid eligibility in the year, this is the number of 103,000 people who lost Medicaid eligibility, what were the services they had used in the last month of their Medicaid eligibility. So these were services that were active at the time they lost Medicaid eligibility. You can see about 1.5% were pregnant, about 41% were actively receiving and using prescription medications, about 10% were in the middle of treatment for mental health or mental illness, about 4% were in treatment for substance use disorders, about 61% had not used Medicaid services in the last month. And then we looked at other smaller, where the numbers were smaller, but if, for example, somebody was in the middle of chemotherapy or other kinds of treatment, and they were small numbers but important numbers. If we looked at the group gaining eligibility, and so this is the group we would anticipate coming into Medicaid from the exchange, higher rates of virtually all of these conditions, and in all likelihood this is what helped contribute to the person qualifying for Medicaid, needing Medicaid, spending down into Medicaid, and so on. But about 7% came in, women were pregnant at the time Medicaid received them, 46% receiving medications, 9% or 10% mental health, 4% substance use, and 67% none of the conditions that we looked at. So that's the issue with churn, is following patients, knowing what Medicaid is receiving in terms of ongoing services we have to support from day one, what the exchange plans will have to provide from day one. And so I'm going to turn then to the next topic area for safety net providers. One of the issues that we addressed in Maryland is building capacity in the safety net community. And let me actually lay this out a little bit more broadly than what's on the slide. One of the studies that we did right after the ACA passed is we looked at what the state budget implications of the ACA would be and where the state might be able to reduce its state grant-funded or 100% state or local funded safety net areas because, for example, people might get coverage in the exchange through subsidized tax credit-based exchange eligibility. And so we started looking at where was Maryland providing 100% state or local funding for safety net needs that might that the state might be able to save some money because people have insurance coverage and they're not uninsured and turning to 100% state-funded safety net. That in turn led to analysis of how safety net providers should become more ready for the ACA and an insurance model so that if the state was reducing grants, for example, to some safety net providers, if the state was reducing grants to free clinics or to school-based health centers or to some of the public mental health system as a grant-funded model, because people have an insurance card and should be able, and the provider should be able to submit a claim, what would those implications be to safety net providers? So we have in Maryland a commission called the Community Health Resources Commission, and it started working on a business plan in February of 2012 for how the state could help support the readiness of safety net providers. The state did a survey of various kinds of safety net providers, FQHCs, free clinics, school-based health centers, Ryan White clinics. We looked at local health departments that provided direct services. We looked at the public mental health system, public addiction treatment system, and providers, and we have this stratified by provider type as well, their kind of readiness to participate not only in Medicaid as a provider who could submit claims, but also in the commercial insurance market. To what extent could they submit claims? Did they have electronic medical records, and so on? We then, out of the survey, the state developed recommendations for a business plan to support safety net providers through technical assistance and other resources to become more active participants in the Medicaid and commercial insurance markets, and how to leverage funding resources in Maryland, including some public funding that in Maryland a lot of this comes through the sort of tobacco tax and smoking cessation settlement types of money, but also with local philanthropy and our local health grant makers. We then worked, the Community Health Resources worked with the state's health department, which includes Medicaid that I lead, but also our public health and behavioral health areas, which also do some grant-funded work and local health departments. We work with the Governor's Workforce Investment Board, which does a lot of workforce capacity building and training programs and loan forgiveness programs, and licensure and scope of practice and those sorts of things, to develop statewide plans and how to translate information into customized technical assistance needs, meeting those needs. So then we looked at safety net providers in two separate buckets. We looked at, traditionally on the left-hand side of the slide, grant-funded providers. These are providers that, for the most part, were not accustomed to submitting claims. They did not have very sophisticated or maybe even existent billing functions, and we wanted to work with them on areas of assistance to help them join Medicaid as a payer who could get paid, as well as down the road potentially the commercial carriers. And the areas of assistance they identified as needing support is credentialing, that is, going through credentialing and contracting kinds of processes, submitting claims, IT support and electronic medical record support, and also developing some strategic business plans to demonstrate the value they add and the value propositions and why MCOs and carriers should want them in their networks. The second group we looked at are providers that really did know how to submit a claim. These are providers with Medicaid experience. They're not afraid of CPT codes. They understand all of that. This included providers like FQHCs, the public mental health and behavioral health system, and local health departments, and they had expertise with claims, but for the most part, the only payer they were billing was Medicaid. They weren't really very present and didn't have much penetration in the commercial insurance market. And areas where they identified needing help to get commercial contracts were how to set prices, how to what the fees should be they should be seeking, how to get contracts through the managed care organizations or QHPs, how to improve efficiency in their practice models, because a lot of commercial carriers expect certain, the phrase is throughput, which is how many visits per day and that sort of thing. Producing outcomes data, because in Maryland, in a lot of our models, we have various kinds of pay for performance and how you produce HEDIS measures and what the HEDIS measures are and so on, and utilizing EHR, electronic health records networks. This led then to further work, such as we're having a series of what we're calling mixers or meet and greet sessions. There are going to be 6 in the state. They're going to be regional. All of the Medicaid MCOs are going to attend. All of the QHPs, the commercial carriers, are going to attend. They're going to have booths. Safety net providers are invited. There's going to be some overview about health reform. There's going to be facilitated contracting discussions, table sessions. It's almost going to be like a job fair kind of model, and we'll have people on site to do technical assistance and also to get follow-up information for technical assistance, and the commercial carriers will be there. And I should note that one of the reasons the commercial carriers are very interested in Maryland is that when you look at the essential health benefits that are in the products in the exchange, the essential health benefits include benefits like mental health and addiction treatment with parity that the commercial carriers simply don't have adequate networks to deal with. This is going to sort of force them to stretch their competencies, their benefit design models, their networks. The habilitation and rehabilitation models and other things are going to force the carriers to extend themselves, and safety net providers are well situated to provide some of that access and capacity. We're also working to build what we're calling a Health Access Impact Fund. This is using the state-funded, our Community Health Resources Commission, and as I said, the tobacco tax and other resources that commission, but also private foundations to create a fund to then provide technical assistance and ongoing support through learning collaboratives and so on. In fact, I'm going to be meeting tomorrow morning, with the Association of Baltimore Area Grantmakers, which includes several fairly large philanthropies in the Baltimore area, for purposes of them collaborating to help build out the safety net capacity and how they can combine their efforts in this area. So moving on, the next topic is delivery system reforms, and I'll just sort of tease this, but not sort of go into as much depth on this area. Maryland has a multi-payer patient-centered medical home model. This includes all payers except Medicare, so commercial insurance and Medicaid are part of our multi-payer patient-centered medical home model. It was launched in April 2001. It has now 53 separate practices, including 339 providers, covers 300,000 lives in Maryland. It includes Medicaid and commercial payers, a variety of practice types, including FQHCs and private practices, and also hospital-employed and hospital-based pediatricians, internists, and family practice docs. And we are a state that many states got state innovation model planning grants, and we are going to be working through that between now and the end of September. And our plans would be to include Medicare and get permission from the CMS Innovations Office to get Medicare included in our all-payer patient-centered medical home model. I should add, the reason that we're doing it on the multi-payer approach is if you've got a medical home, a group practice or an FQHC that is doing a good job with what we would expect from a medical home in terms of care coordination, using electronic health records, making referrals, following their patients, doing prevention, and so on. If we can leverage all of the payment streams into that practice, including Medicaid, including commercial insurance, it's much likelier that that group practice is going to adopt those changes because it's across their whole panel of patients. And so it's a way of really helping with these practices reconceptualize and re-engineer how they do care and how they use physician extenders, how they work back out into their communities, work with local health departments, track patient health, without having to pay attention to whether that patient happens to be covered in a medical home based on who that patient is insured by. It's a way of helping to transform the whole practice. Second, we are moving forward in Maryland with a health home model. This is under the Affordable Care Act. It's more, I think, familiar than it used to be with states and providers and safety net providers, but it's the federal government is offering enhanced Medicaid matching funds to help expand health homes into areas where there's chronic illness and also specialty behavioral health needs. And we're building out a model where, in effect, the behavioral health home could be in a specialty behavioral health setting, like a specialty mental health provider or an addiction treatment provider. And what we're going to expect from that health home is linkage to social supports for individuals who have serious and persistent mental illness or addiction disorders, and that leads to poor social outcomes about employment, housing, in and out of jails, staying involved in the educational system, and so on. And so we're including those kinds of outcome measures in our health home model, and FQHCs are entities that can participate in that health home. And what we're going to be doing in Maryland is paying a fairly significant per member per month case management or administrative case rate on top of what we would then pay for actual service utilization. So the remaining holes in the safety net, and I have a couple slides here, and then I'll turn it over to you all for questions. We are aware that in the safety net, there are going to be holes. For example, the expansion of Medicaid and insurance, there will be a number of people who remain uninsured, most predominantly people who are undocumented. They're not eligible for Medicaid. They're not eligible for advanceable premium tax credits in the exchange. We have, a significant group of people who are immigrants in Maryland and is certainly true even though we're not a border state. And so we know that there needs to be an ongoing safety net for undocumented aliens, and a lot of clinics, free clinics and FQHCs and others will continue to need grant-funded support or other forms of support for that, and as well as people who choose to go bare even though they were eligible for coverage. In addition to that area of the safety net, the second major bullet on the slide, as I mentioned, some Medicaid-covered benefits are not going to be included in the exchange benefits, and this includes things like various residential treatment programs for behavioral health. Medicaid covers residential treatment, but the QHPs are not likely to have very significant care in those areas. And so if you have somebody who needs residential treatment and they're in the exchange, we may need to have an ongoing state safety net wraparound for the QHPs. And so we're trying in Maryland to figure out how to size the ongoing state and local grant-funded role to support the safety net, both in terms of people who don't have coverage and people who need benefits that are not included in the QHPs. And we're identifying where the point of access for those individuals is, which certainly includes safety net providers like free clinics, the public mental health system, FQHCs, and others. So that concludes my formal presentation, and I want to turn it over now to the moderator for managing the Q&A if there are any questions.
Thank you, Mr. Milligan. If you have any questions, you can type them in to the response box, or you can press the hand to raise your hand to ask a question. And I'll just give everyone a moment to ask any questions that they have. And but while we're waiting, you have discussed that it's possible that, Mr. Milligan, that there might be some cuts in funding to FQHCs. And what is Maryland going to be doing, and could this reflect across the nation to help with FQHCs if the funding is cut once the exchange programs are implemented?
In truth, we weren't, and I may have said this, but I want to clarify, and thank you for the question. We were not on the state side anticipating cuts, but with sequestration and with some of the federal budget issues, we wanted to plan ahead in the event that the federal government, through HRSA or other sources, felt pressure to make cuts in grants because of the fact that more people have insurance coverage. And let me make sort of two quick points about that. The first is that in the ACA itself, one of the safety net subsidies that goes to hospitals is the DSH, or Disproportionate Share Hospital Program, which in fact was cut on the theory that hospitals would be seeing fewer people who are uninsured, indigent, in need of charity care, and therefore the federal government could cut the DSH grants that state Medicaid programs used to subsidize hospitals that had high volumes of uninsured or Medicaid. And so we've seen an example already in the federal government where they have reduced or stepped down payments to safety net providers on the theory that there are fewer people who are uninsured and therefore you don't need to have as many subsidies and grant-funded programs. Now, but the second point is I've heard that as HRSA has been providing information out to their grantees, that HRSA is trying to protect and level fund the grants they've been making to HRSA-funded safety net providers, even though sequestration is putting pressure on the federal budget. So I think short term, Maryland doesn't intend to cut any grants to FQHCs, and I'm told HRSA is trying to at least level fund their safety net providers. But I do think that it's in the interest of safety net providers, including FQHCs, to strategically build a business model that will try to capture more third-party insurance, including Medicaid, in the event that down the road the federal government seeks savings in that area on the theory people have insurance.
Okay, thank you. Are there, just waiting for some more questions, or any other questions that are coming through. Let's see. Oh, sorry. Let's see. Just one moment. Okay. How will the meet and greet information be distributed?
There are a couple of different strategies about that. The state has already released the kind of save the date announcements about when these will be held in the various regions of the state. An agenda shortly will be circulated that will include, they're all going to be 2-hour-long sessions. The plan is for an initial 30 to 45 minutes of kind of overview of the health reform law, the essential health benefits, the coverage requirements, followed by about an hour and a half or an hour and 15 minutes of the kind of job fair meeting and greeting and tables. So what the state is going to be producing is the save the date, some general overview materials, and a general agenda for the sessions. What each of the insurance carriers, the QHPs and MCOs, will have at their tables will be information on how to get contracts, information on the credentialing process, and they're going to have provider enrollment individuals on site and have literature on the various insurance carriers to do some overviews, handouts, and then follow-up subsequent to these sessions. And they will be producing those materials.
Okay. The next question is, what role do you see for faith-based organizations in assisting your mission? And is there defined interest in coordination with communities through faith-based, and would there be budget to engage these organizations?
Well, in Maryland, we certainly see a role for faith-based organizations. And one of the things I didn't really touch on a lot or at all in the presentation was just the role we're hoping to have from the safety net providers, simply in terms of getting people insured and getting word out about eligibility and the coverage expansions, and we're open for business to cover more people, and how we can get eligibility support through the safety net providers. A lot of the faith-based organizations in Maryland will be playing a very significant role in outreach and education to consumers to help increase Medicaid enrollment and get people covered through the exchange. But faith-based organizations also have other roles, including being related to some of the philanthropic organizations that we're hopeful will help create this healthcare access fund and also provide some of the technical assistance. And they are also working back through their local community providers, their local FQHCs and free clinics to provide grants and support in those ways as well.
Okay. This next question, besides primary care, are there any specialties?
Well, there are specialties. On the Ryan White side, in terms of immunology, we're looking for support. We're looking for support certainly on the behavioral health side with mental health providers and addiction treatment providers. With respect to kind of general medicine specialties, we all are aware that there's going to be more demand for all kinds of specialists. And in Maryland, we're doing a number of things to try to encourage more specialty provider participation, including increasing some of our Medicaid payment rates. And to the extent that safety net providers offer specialty care, that would be included in many of the points I've already made. But a lot of the safety net providers in Maryland, the vast majority of services they provide are more primary care in nature, and then some limited support for, or not limited, but behavioral health supports as well.
Okay. You had discussed facilitating access to data and interpreting or translating this data to meet customized needs. Would that actually, is that something that is would be part of a business plan for the exchange, or or for the FQHCs to implement?
So the Community Health Resources Commission, which developed some surveys that they released across different safety net provider types about a year and a half ago, and then compiled the results. They tried to figure out what kinds of technical assistance and other supports were needed. And so what we do anticipate is that the business plans will link what providers need based on where they are in terms of kind of a spectrum of readiness, if you will, for becoming in-network providers, whether it's patients at a medical home or submitting claims and so on. So where providers are on that continuum, we're developing technical assistance modules and consultants that can help each provider meet their own kind of unique needs along that continuum. And so the surveys that were done and the data that was collected related to that were really to help identify the kinds of expertise and technical assistance and consultant support that we would need to have available to us to then offer to the providers.
Okay, great. Well, I think that's all of the questions that I have here. Unless, is there anything else that you would like to ask or add, Mr. Milligan?
No. If anybody has a question later and they want to route it to me, that would be fine.
Okay.
My email address appears to be on the screen, which is certainly good. People can send me a note directly.
Okay. Excellent. Well, I would like to once again thank everyone for attending this important the health change is supposed to be implemented this year, and we appreciate Mr. Milligan for your time and your expertise on this topic. And I would like to give a big thank you to Devin LaPointe for always being a great organizer for this the GoToWebinar. So thank you, Devin. And if any of you need any training or technical assistance, please contact one of our talented staff members for assistance. And thank you once again for attending. And we are, this year we are hosting the Health Center and Public Health National Symposium, Keys to Healthcare in Denver, Colorado, from June 4th through June 6th. Please go to Reg Online, or if you have any questions about that, call me at 703-812-8822, and I'm happy to give you more information. And once again, Mr. Milligan, we absolutely appreciate your time and your expertise, and everyone have a great day.
Thank you, Tricia.
You're very welcome.